But here we go. This is case number 52. Officially a whole year worth of cases now. So this is the case for today. This lady is a gravida 3 para 2. Her last baby was 4.2 kg and she had a shoulder dystocia with this baby as well. This was an SVD, as was her previous one. I believe the last baby was born in 2021. Medical history wise, she was hypothyroidism and she was on levothyroxine, I think 75, which was upped during her pregnancy from 50. She had a BMI of 34 and she had a B12 deficiency where she was being seen in day assessment unit, I think every other week for B12 injections. 36 weeks, she had an ultrasound scan, normal fetal growth, Dopplers and Lycor. Estimated fetal weight was on the 84th centile, which I think made her baby roughly guesstimated to be about 3.2, 3.3 kilos. And then at 39 plus 3, she had reduced fetal movements and she was seen in triage for this. And then as per our sort of protocol, it was recommended that she have an induction considering she was past 39 weeks. So she was admitted on the 12th of the month for an induction of labour for reduced fetal movements. She had a baseline CTG at 1:30 p.m. where the baseline heart rate was 140. I think due to prescription and the acuity on the ward at this time, they didn't start it at that point. She needed to have it started a little bit later. She had 5 minutes of CTG prior to induction of labour. Obviously we would like a minimum of like 20 minutes prior to putting in any kind of hormonal induction, just purely based off of the fact that we need to know that this baby is fit for labour to start off with. But at 17:45, she was examined. She was found to be sort of multips os, I think it was -2, -3 at this point, and a propus was inserted. At 18:08, as you can see, quite a lot of loss of contact. They did check maternal pulse, which was 94 at the time, and the transducer was adjusted at this point as well. Her baseline set of observations: blood pressure 132/80, pulse of 100, temperature of 36, and a respiration rate of 18 with SATs of 98%. And 19:45, sorry, so this is your baseline CTG here. So this is the sort of 45 minutes post induction of labour CTG that we've got here. One thing to sort of note is something I always say: please make sure you're looking at the previous baseline whenever you're doing a CTG, specifically for women that have been induced. She's already having a couple of sort of random contractions / tightenings. She wasn't feeling any of them at this point, and they weren't reported to be sort of strong or anything like that at all. But note the fact that her baseline looks to be around 150. Not more than a 10% increase, but for me personally, I'd probably like to see a little bit more CTG here before we continue with taking her off. Also, apologies for the background noise. My neighbours have given their child a whistle this afternoon. So what do we think? Everyone happy to take this CTG off?
No.
Why not?
By the look of it, the baseline, we started with a baseline of 150. We want to observe it, and by the look of it, the variability is looking more or less than 5, most of it.
Yeah,
and
sorry, bitch, just go on.
There is some loss of contacts whereby we don't know whether it is accelerations or so I would keep it on.
Yeah, I totally agree with you, Beatrice. For me personally, I would have kept this CTG on a bit longer as well. We want 40 minutes after a propus of good CTG. We've got a lot of loss of contact here. It's not for long enough periods for us to think, okay, yeah, maybe she's decelerating and there's a possibility that this baby is hypoxic already. But at the same time, we really need to get better contact and be really reassured by a CTG before we remove it. Unfortunately, that wasn't the case with this lady. She had a repeat CTG at 1945. However, that also had lots of loss of contact, was discontinued and considered to also be normal. I think this lady's BMI was 34, and I think she carried some of her weight in her abdomen. So that meant that when they were trying to put her on the CTG, there was a bit more difficulty with that, which is obviously, that those things happen. However, if that is the case, I would recommend that maybe we sit there for a little while and just try and get the best position for the transducer to be on the abdomen so that we are picking up this fetal heart rate correctly. Specifically as well, if you're repeating it and there's still loss of contact, then there's lots of different ways we can try and combat that. And it's not reassuring when you've got a lot of loss of contact because you can't make an overall analysis of how this baby is getting on. I'd also think with our reduced variability this early on, is a ProPES the best form of induction when it comes to this woman? If we're giving her an artificial hormone that's going to increase her contractions, that could increase stress, we want to make sure we've got a non-stress fetus to start off with. And this isn't reassuring me of that at this point. So we continue. So she had another CTG, like I said, at 1945, and the CTG was lots of loss of contact and was discontinued. On the 13th, so this is a few hours later, so this is just 1:30 p.m. 1:30 a.m. after her CTG's been put on. She's continued care on antenatal ward. As you can see again, lots of loss of contact. I say this probably weekly as well. My favorite little letters, LOC. As fantastic as it is that we can write that down and say, okay, there's a reason why there's a lot of missing trace. I want to know what we're doing about it. It's great that we're recognizing the fact that we need to adjust the TOCO and whatnot, but okay, can we maybe try moving her into a different position? Do we need an additional pair of hands to help monitor this baby effectively? And have we escalated the fact that this is a concern now? So they managed to get contact within the last sort of 25 minutes of this segment. This bit does continue on a little bit, but I'll just show you the next sort of slide here. Is anybody, this CTG was noted to be normal. Does anyone agree or disagree?
Me personally, I'm still not feeling great about the variability.
Yeah.
And
I think there could be some shallow.
Yeah. Yeah. So if I just take you back to this one, I think it's slightly clearer with that sort of around the third blue bar, if you like, at 155-ish. What I'm seeing here is exactly what you are, Indra, in that these are sort of shallow, sort of more chemoreceptor mediated decelerations here. And these continue, I think, with the majority of those contractions. You can see they're late to sort of start and they are shallow, with reduced variability as well. We've not really had at this point any reassuring signs that this fetus is fit for labour or well at this point. The baseline is still stable, which is good. I say the variability in certain areas is slightly more than 5, but for the majority of this trace, we've got some reduced variability and we've got chemoreceptor decelerations here. So if we could go back in time, hindsight, as we know, is a wonderful thing. If we could go back in time, would anybody do anything differently?
change maternal position.
Yeah. When we've got chemoreceptor or shallow decelerations, though, these are normally due to things that like changes in the fetal pH as opposed to changes in fetal blood pressure. So if these were sort of more baroreceptor decelerations, I think changing the position is likely to maybe have an impact. However, you've got reduced variability and chemoreceptor decels. What's she been induced with?
We should I think, it's one CTG that you probably need to be reviewed urgently. Probably remove the ProPES because this baby is not showing any sign that it's actually fit for labor.
Yeah.
We might even want to think about giving Trabutin to take away the stress, the contractions.
Yeah, she's contracting, as you can see, sort of 2 in 10. I think these were noted like mild on palpation, but she was feeling them. I think she got given some dihydrocodeine around this sort of time as well. I think towards the sort of end of the CTG here. But what concerns me about this one is the fact that this was noted to be a normal trace, although those decelerations are quite subtle. They are present. However, this wasn't reviewed by an additional midwife or an obstetrician, and was noted to be normal and then removed at 3 o'clock in the morning. Human factors wise, obviously, we're going to consider the fact that 3 o'clock in the morning, nobody's at their best frame of mind, but it's definitely something that if we're ever concerned, or if we maybe think that there's a possibility that something's not quite normal, then escalation and getting a fresh eyes review is going to be really, really important here. Cool. So I haven't included all of the CTGs because there were lots of them. Thankfully, the CTGs that were done at 10 a.m., 1640 were both normal. Baseline rate was 140 with good variability and accelerations present as well. This is the other thing. This is an antenatal lady. We would expect to see some form of accelerations to give us that reassurance in this sort of part of her labour care as well. If she is in sort of labour, then they're not necessarily as relevant, but definitely in the sort of antenatal phase. And then she continued to have CTGs at 1850 and 2100, both of which were completely normal, again, with a baseline rate of 140. Her next CTG, this was now the 14th, at 0005, she was given, sorry, I should have mentioned she also had a prostin there as well. So she's given her 2nd milligram of prostin at 0005. Because unfortunately is not ARMable at this point. I think the cervix was 1 centimetre dilated. Station was -3. At 0040, she is changed position to sort of sitting more upright. And then at 1 o'clock in the morning, the CTG was reviewed by the case midwife and was found to be suspicious because of the tachycardia now of 160. So position change again was done. We're in a bit more of a sticky situation now because obviously when it comes to what can we do to try and fix this, we've given prostin. This is not something that can be removed. So if we were ever in a difficult situation here, then we would have to give sort of tocolytics. But what else could we do with a baseline of 160? What else would we be doing or looking out for with this woman or with this baby? And what would our plan be?
Do you want to know if she's got temperature? What's her pulse like?
Yeah,
If she's got an
absolutely.
infection?
Yeah, absolutely. So definitely a set of maternal observations, see if the mother's tachycardic, see if she's got a temperature, maybe do a septic screen if it is sort of that borderline or if it is over the sort of threshold that we would suggest. Anything else? She's still on antenatal ward.
She'll need to be transferred to labour ward because you've got the reduced variability, you've still got some shallow D cells, and they're quite subtle, but they're there.
Mm.
It's more like a chronic hypoxic trace.
Yeah, so definitely chronic. I mean, if think about it slightly differently, chronic hypoxia is normally a predominantly antenatal concern. So chronic is normally caused by something antenatally that is sort of an unfixable situation. However, we've had normal CTGs before, so the likelihood of it being a sort of true chronic hypoxia is quite small. We've also given her a ProPES and 2 milligrams of prostin at this point, so we've caused this.
We've created it, yeah.
Do you know what I mean?
Yeah.
So yeah, and also just just being able to sort of escalate that is key. She's also contracting now sort of 3 in 10, 4 in 10. I think these were picking up at this point, and they were she was in a little bit of distress here too. So the CTG continues. She remains on antenatal ward. Her observations are checked, which is great. A cannula was sited, an FBC and CRP were taken, and some IV fluids were started. And then at 01:25, the obstetric registrar and the midwife in charge came for a review. And a plan was made that if there's no change within 1 hour, then she needs to be transferred over to labour ward. I think the premise here was that the fluids would be the answer to sort of fix this CTG.
So this is the first time that obstetrician and the midwife in charge has looked at the CTGs, eh?
Yeah.
Okay.
The obstetricians obviously did a quick review of her notes and whatnot before the suggestion of starting the induction, but she wasn't reviewed afterwards. So this was the next time that she was reviewed. So we're now like, I don't know, 36 hours after she's been admitted. We've also got a lady, what was the initial reason that she came in was for reduced fetal movements. We've still, well, there's arguably accelerations here, but we've also spent a lot of time in a very much reduced variability. Whether or not this is cycling and this baby cycles for longer, I'm not sure, but for someone that's antenatal, that's 1 centimetre dilated and has had previous reduced fetal movements, I'd be even more aware of the fact that we need to keep a much closer eye on this CTG. Okay, so the CTG was that was when the CTG was taken off at this point. I'm not quite sure why. I think due to that paper jam, and then it was restarted here. So now it's 2 o'clock in the morning. Those blood results came back. CRP 9.5, white cell count 10.9, and her HB was 121 with platelets of 147. Again, this continued. We've still got reduced variability. We've got a baseline of around sort of 150 here as well. And again, we've got some decelerations present too. At this point, I'd be thinking, okay, there's something going on. This baby's trying to tell us they're not loving the induction process. How many centimetres dilated is she, and what can we do about it? Ooh. Anyway, she was transferred over to labour ward, and this was her CTG on labour ward. At this point, the CTG, as you can see, has very much normalised. We've got some accelerations present now. We've got some better variability, and our baseline sort of sat around 140 again, so all reassuring. But it does just sort of bear the question, okay, does a CTG that's previously been quite poor magically change? And if so, what's the reason behind that? And what necessarily have we done to do that? Is it the fact that we've given fluids and this mother was significantly dehydrated and that's had an impact? Or is it something a little bit different? Mr. Naguib, I don't know if you want to comment on that at all.
Personally, I think it is the quality of the machine. It is the one on Hope Ward was also slightly, I feel like there was no ink. This is more giving me the drawing. I don't know. I feel like there is no difference in time for it to improve so much.
Strange, isn't it?
Yeah.
Perfect.
Hopefully, with your new machines, this will not be there.
Yeah, I hope so. I really hope so. Blood pressure has also gone up a little bit, so 140 over 83, pulses 95, respiration rate of 23, temperature of 36, and SATs of 96%. She's also deep breathing now through these contractions, which could explain her raised respiratory rate. But I mean, I'd much recommend doing a respiratory rate when she's relaxed, if this was the case, and it's not really documented very clearly. but we'll move on. She did a urine dip at this point. She went out to pass urine. Urine dip was completely normal, and the CTG was reviewed by a second midwife and was agreed upon as normal at this point. This is quite a few slides, so I think we'll just kind of skim through a little bit. This baby is showing us some wonderful cycling here. So we've got some good variability in that sort of 20-minute period. Then we're going through a bit of a sleep cycle from what it looks like, and then it picks up towards the end, which is all really reassuring. Reassuring me that this baby is coping with the stresses of labour with those contractions as well. This continues again. CTG fresh eyes review is reported again as normal. Again, a bit more cycling, and then we pick up again, and then we go back down again, although our baseline is possibly making an increase again here. At 6:30, her cervix is examined by her case midwife. And she reports that the internal os is closed, but the external os is 2 centimeters dilated. So an ARM was not performed. However, the case midwife asked the midwife in charge to redo the examination. And the midwife in charge found her to be 3 centimeters dilated, and an ARM was performed. At this specific point, there was clear lichal. Then we had a very long period of time of loss of contact before an FSE was placed by the midwife in charge, and meconium stained lichor was noted here. But babies responded very well to our examinations, as you can sort of see here when the FSE was put on, and also where she was examined in ARM before. This baby responds really well to those examinations. Again, more reassuring signs that this baby is also well. This is then continued. The second litre of Hartmann's is started at this point. Baseline sort of sat 145, 150. And we're definitely getting some more decelerations towards the end here with a bit of reduced variability. So again, going to keep a bit of a closer eye on that. This continues. At 07:45 in the morning, terbutaline was given due to the reduced variability, chemoreceptor decelerations repeatedly. Just out of interest, does anybody else would have given it or not given it based off of this?
I would have given it, and possibly, like according to the examination, the examination was 3 centimeters, isn't she?
She is now 3, yeah. So this was your sort of half an hour, those sort of decelerations that you can see,
Yeah.
and then this was when terbutaline was given at 7:45 in the morning.
Yeah, I would have given it at 7:45 in the morning, and seen what happens next, really.
What would
I am
be,
yeah,
sorry.
one as the reg on, for example, I'm approaching the 7:45. I'm approaching the handover. It's not the best time to do C-section. If we eliminate the timing factor, I would have examined her myself, and if she is still 3 centimeter, I would have given terbutaline and moved to theater. So by the time the new people come, they section her straight away. If I am eliminating the time factor.
Perfect. Thank you, Mr. Naguib. What is it that would be your like initial concern from this? Just with the reduced variability?
Not only the reduced variability and the baroreceptor deceleration that is on, especially the subtle ones in the beginning of the trace of this one, then at the end as well, and the fact that there is no shouldering, there is a bit of no variability inside the deceleration. um, I have been concerned from the beginning about the variability. So overall, I am 3 centimeter. I am previous shoulder dystocia. I am like I feel like I am heading towards a tired baby at for the sake of having a vaginal delivery. And so if I am not at 7:45, I would terbutaline and go to theater. If I'm 7:45, I terbutaline and go to theater for the next team to section her.
Perfect, thank you. So terbutaline was obviously given here. Respiratory rate was recorded as well as the temperature being 36.8. We're now approaching a handover here as well. So just bear that in mind. Baseline's sort of 150. Baby picks up here. I think the contractions do somewhat slow down, which is obviously going to benefit. Variability picks up nicely. And then our baseline sort of comes back to around sort of 145-ish here. And we've got some possible accelerations as well. At 8:45 in the morning, the ward round come round and they say suspicious CTG based off the whole clinical picture. And the plan was made to increase Hartmann's and remain and keep this woman nil by mouth. At 8:50, she went out to the toilet and passed 500 mils of urine. This one wasn't dipped though, unfortunately. Blood pressure at 9 o'clock was 125/70. She's now got a pulse of 107 and a respiratory rate of 18 and a temperature of 36.5. Our baseline has made an increase. Obviously, the terbutaline is still very much in effect in terms of its sort of lifeline, if you like. I don't think that's the right word, but I think you know what I mean. And we do sometimes expect an increase in maternal and fetal heart rate as a result of terbutaline. So that's to be almost expected, and our variability is good here. So we continue. She sat into the throne position here. Contractions still sort of spaced out to around 1 to 2 in 10. Baseline around 150. At this point, their fetal heart rate goes very much up, although I don't know whether people would argue that the baseline sort of sat at around 155. We've possibly got some decelerations and accelerations here as well, but this baby looks a little bit either awake and a bit erratic, or the baseline's very much on the increase and these are decels, or it stays as it's normal and it looks like accelerations. But what does anybody else think?
I would say the baseline is 150, 155, and this is acceleration.
Perfect. Anyone disagree?
It's difficult to really tell on that, to be honest.
It is, isn't it? Because I mean, obviously this is the thing that I often find is where your variability sits at the most like the best, if you like, is normally sat at around the baseline. And that's just where obviously where gas exchange is taking place, this baby's normally at its happiest, which is why I would agree that this is sort of sat around 145, 150. But you could definitely, from a faraway glance, look at this and think, okay, is this baseline now actually 170? And are these decelerations that we're seeing? Which is again why Miss Nikki would come in and say that obstetrics is very much an art. And the only thing that we can really do in this sort of situation is to continue the CTG for a little bit longer to see if the baseline does sort of settle and remain in the right place. But we need a baseline to sit for at least 3 minutes at the baseline for it to be considered a baseline. So this is it continued. Fresh Eyes Review says that this CTG is normal. Contractions have now spaced out again to sort of 1 in 10. This one's got no pain relief on board either, by the way. But I think towards the end of the CTG, we can sort of successfully say that this baseline is much more sat at around 150, and that this baby was probably jumping for joy that it was the morning time and sunrise was coming or something along those lines, and possibly very active, although that's not really recorded in the in the Cerner records. So just as a sort of addition to your documentation, If you are seeing something like this, do make sure you sort of feel or ask the mum if she's feeling movements, because that can really help us when we're assessing the whole overall clinical picture here. Perfect. She vomited 500 mils at around 10:42 in the morning. And then as per sort of the 4 hours guidelines, she was examined and she was found to be 4 centimeters dilated, not well applied, partially effaced. And at 10:59, she was consented for a cesarean section. Anyone agree or disagree with the plan?
What made them jump suddenly?
I think the reason for this was due to sort of failure to progress, if you like, but there's not really any major clinical decision, if you like, in the Cerner notes for this woman. She also hasn't had a set of observations done since 9 o'clock.
Mm. Yeah, what was the examination is 4 centimeter. Yeah, in a sense, I agree that overall we are going nowhere, and we have started not in the right way, and CTG was not perfect in the beginning. Then we wanted to section a while ago. I mean, I agree with the decision, but I would put it as a failure to progress, as you said.
Mr. Nagee, was there anything else that you would have maybe sort of recommended before the decision was made for this?
Uh,
Is this the sort of CTG that you'd be happy to sort of start Synto on, or anything like that?
Not really. No, not this specific one. The one that we give terbutalidone, and like, and we have been for the last 4 hours decreased variability, and I mean, it's no, I wouldn't be starting Synto on that.
Okay, thank you. This lady, the CTG continued as per normal. An indwelling catheter was placed at 12 minutes past 11. And then at 11:14, whether or not we were going to debate about this baby being born, the deceleration was noted at 11:14 with no signs of recovery. I mean, I'd argue here that it looks like it's coming back up, but obviously I wasn't there at this specific point in time. And because the plan was for a cesarean section, we initiated the sort of 3, 6, 9, 12 rule, although we did it quite quickly. And then this lady went to theatre. At 11:16 in the morning, she went into theatre. 4 centimeters was found by the consultant, and due to the fact that this fetal heart rate was still down, the decision was made for a Cat 1 emergency cesarean section. This lady was put under a general anaesthetic, knife to skin and knife to uterus at 11:25, and delivery within a minute. You can see that it gets very, very, very saltatory here as well, which is normally a sign of neurological instability. And that's on top of the fact that we've had a deceleration with almost pencil tip variability here. So I think that was quite good in terms of the very quick decision making to convert to a general anaesthetic. Anyone want to guess the outcome for this neonate?
One 6.9. Gas 7.1. Yeah.
Anybody else? Everyone's being shy tonight, Mr. Naguib.
Maybe because I jumped and said whatever I thought nobody wants to say. So I'm sorry.
Well, I'll put you out of your misery. This baby was born with APGARs of 8, 9, and 10, was on the 76th centile, so our ultrasound department were very, very spot on. Arterial pH of 7.12 with a base excess of -4.6 and a lactate of 6.1, and a venous pH of 7.20, base excess of -5.4 and a lactate of 5.1. This baby was born with in sort of very poor condition initially, and so delayed cord clamping didn't happen, but as soon as the baby's cord was clamped, they started screaming, which is always the case when we've got clinical concerns at birth, isn't it? But nasal cannula is required for this baby. This baby had intermittent tachyapnea as well and query meconium aspiration. So was admitted to SCBU and was later diagnosed with sepsis. As this baby started to deteriorate on our neonatal unit and had a CRP of 27. This baby's very well now, which is great, and has been discharged, or was only an inpatient with us for about 4 days, I think. Went up to transitional care after 2. But yeah, any questions at all?
Tara,
Yeah.
and you said the gestation was 39 or something?
Yeah, so at delivery, I think baby was 39 and 5.
And there was meconium as well.
Yeah.
So baby right from the word go was not having any any will of carrying on with the induction of the stresses because it was already stressed.
Yeah, so absolutely. I mean, meconium in itself is very common, more so in women that are very much post dates due to sort of gut maturation and whatnot. But for this neonate, I think that was our initial sign of distress, and actually not that we would have done, but maybe if we'd have found she'd have shrom a lot earlier on, sort of at the start of her induction, my assumption here would be that we would have found meconium a lot sooner. Obviously, there was no need for us to do an ARM at that point, and obviously we want women to sort of go through the process naturally, but I think this baby probably did a poo inside from the start of the induction process, and it just obviously took a wee while for us to detect it until her waters did actually break in the end. But yeah, this baby was, well, had already, if we would have seen that, I think we would have acted a lot quicker, from all the way back to the beginning of her stay on antenatal ward, because those sort of two things in combination together would have needed escalation a lot faster. It's just a shame that we didn't necessarily pick up on those abnormal antenatal CTGs previously, which is again going to lead me to another very, very key point, and something that I do nag about very often is the fact that we really, 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 when we're reviewing any woman's CTG, need to go back to the original baseline so that we can accurately say this baby's not hypoxic, because a normal range of baseline is from 110 to 160. Obviously, we know that that comes down as the baby matures in utero, but actually we could have a baby with a baseline of 140, which we look at and think is normal, but we then, if we don't look back at the previous and find out maybe it's 120, then we're never going to know that that's not necessarily correct for this baby. So I cannot stress the importance of looking back on your previous CTGs, because I don't believe that this was done for this individual.
I mean, thank you, Kara, so much for the lovely case, but I mean, again and again, it is proving, as you mentioned, that we are sometimes trying to prolong the inevitable for the sake of, I don't know, sometimes fear that we are
Mm,
jumping too early, or for the sake of the 7:45 in the morning, the timing,
mm-hmm,
or for the sake of laziness, or for the sake, there is many reasons why we sometimes, although we are totally convinced that we are not going into the right direction, we want to, like, say to ourselves, no, let's give it this, let's give it this, let's give it this. From the beginning, when we said the variability and the deceleration, then fantastic, we are fantastic. But CTG becomes worse at 2 centimeter, 3 centimeter. I'm not sure why we insist on giving terbutaline but not prepare for theater, giving terbutaline and wait, giving, yes, terbutaline is absolutely great drug. I love it, but I use it in the right context. I want to use it to uh like delay, because I am 7, 8 centimeter and I might be reaching full dilatation. I want to do it and go to theater. I want to do it because I have a second case in theater. I there's many reasons I do it, but it's not only to pass the shift. Uh, I don't know. Again, it is mind-boggling to me that we want just to delay the inevitable.
no, I totally agree. I think we see this incredibly often as well, but it's just all about changing the dynamic and changing the what's the word I'm looking for? Changing the attitude towards a lot of things.
The culture, yeah,
The culture, exactly.
yeah. It's a culture of no fear, and it's not a culture of, because some people will also use it and abuse it in a sense. Oh, let's section and finish. No, it's not about sectioning and finishing. It is about sectioning in the right time, waiting in the right time. It is a timely decision, and in the fullness of time, as they say in some of the religious books. But in you need to come in the right time and intervene in the right time.
Absolutely. Does anyone have any more questions or anything they want to add?
I think maybe we're probably under the impression that terbutaline will probably fix the problem for us, rather than it gives us a breather to get things ready. I don't know. That's why
You
we
are
kind of give
you are absolutely spot on, Indra. You are absolutely spot on. It gives us a breather to reach a goal of some sort. It
Mm,
is not a drug that we are not activating the magic wand on the baby. We think that it is a nifedipine that will lower the blood pressure, or it is uh, Tegretol who will be given for seizures. It's not. It's not. We are not giving this to treat the whole situation. You spot on said it. It is a breather for half an hour, for an hour or so, to give me a bit of time to do something. I'm 8, I'm 9, I am multip, I am para 6. I'm giving terbutaline, uterus relaxes, baby relaxes for a little while. Oh, fantastic, I'm fully +1. I can pull the baby out, or the baby comes out. I am fully, and I want a breather for head descent. I am 3 centimeter, 2 centimeter, and I'm going to theater. I give it so I can have spinal. I am 2 centimeter and I have given it already, but there is one patient inside having a major obstetric hemorrhage, and I have one theater. I give a second terbutaline. I mean, we need to act on the terbutaline as not as the remedy. It is a breather. Yes. No, thank you.
Perfect. Thank you, everyone.
Thank you so much, Cara, for the lovely case and for the discussion.
No
And
problem.
congratulations on reaching 52. Well
Thank
done.
you. I'm on annual leave next week, everybody. So there won't be a case next week, but I'll see you again the following week.
Thank you.
Thank
Bye-bye.
you.
Thank you very
Bye.
much.
Bye.
Bye.
Thanks. Bye.
Bye.